In part one of this talk, I outlined the hemostasis lab abnormalities seen in COVID patients, risk factors for VTE, and then highlighted the primary incidence data in this population. A signal of increased VTE risk in COVID-19 patients is clearly evident. Now my focus is going to be on how to mitigate this risk. So to answer this question, we must first go back to our guiding principle in caring for patients. First, do no harm. In order to uphold this promise, we must not adopt anticoagulant therapeutic strategies that could place patients at competing risk, such as bleeding. The other point to consider is that not all COVID-19 patients are the same, as illustrated by these three examples. So I have three cases here, very different ICU or general ward or outpatient COVID patients. So in the first case, we have a 52-year-old ICU patient that's mechanically intubated for ARDS, a very high D dimer, a mildly prolonged PT, a normal PTT, mild thrombocytopenia, and a very high fibrinogen. Case two, we have a 42-year-old who's admitted to the general ward for COVID-19 pneumonia. This patient is hemodynamically stable, also has a very high D dimer, normal PT, PTT, and platelet count, and a mildly high fibrinogen. And then you have case three, which is a 25-year-old college student who tested positive for COVID-19 after his roommate tested positive, has very mild symptoms, normal labs, and recovering at home in isolation. So how do we treat each of these patients? Traditionally, for any acutely ill hospitalized patient, we assess the risk of VTE on admission to guide VTE prophylaxis. There are several validated risk assessment models for non-COVID hospitalized patients that are available. However, given the relatively high rates of VTE found in early reports, the use of a universal thromboprophylaxis strategy for all hospitalized COVID patients, unless there are contraindications, may be a more appropriate approach than an individualized VTE risk assessment. Now, how does one decide on which pharmacologic VTE prophylaxis regimen to use? At the very least, standard dose regimens are essential. This includes low molecular weight heparin daily, with dose depending on the particular low molecular weight heparin drug used, or unfractionated heparin, 5,000 units every 8 to 12 hours. Low molecular weight heparin is preferred if the creatinine clearance is at least 30, as daily dosing minimizes exposure and PPE use. DOACs, or direct oral anticoagulants, for prophylaxis should not be used routinely as inpatients, and providers should pay attention to renal dysfunction, in which case unfractionated heparin may be preferred. Since COVID-19 is inherently pro-thrombotic, we just need to make sure we're assessing the thrombotic risk as well as the bleeding risk. Now, I've already mentioned that the bleeding risk is quite low, so it's going to be a rare COVID patient that has true contraindications to pharmacologic prophylaxis. However, if you are in that scenario where there's a true pharmacologic prophylaxis contraindication, at the very least, mechanical prophylaxis should be utilized. And it's important to note that the markers of coagulopathy, such as a prolonged PT or PTT, in and of itself are not contraindications to prophylaxis. Many institutions, in an effort to reduce thrombosis events, have implemented empirically higher doses of thromboprophylaxis, now that we are seeing some preliminary data showing higher rates of breakthrough thrombosis on standard doses. However, this strategy is in no way standardized and varies. Some institutions are basing intermediate doses on weight or BMI, others using ICU status to dose escalate. Some have used D-dimer elevation and clinical severity. The approach is not entirely unfounded. There is evidence from other high-risk populations, for example, trauma patients, bariatric surgery patients, and even H1N1 influenza patients that are critically ill, showing safety and efficacy of empiric dose escalation of VTE prophylaxis. But ultimately, we really do need to wait for prospective and preferably randomized controlled trials comparing dose escalation and standard doses to confirm the benefit. Outside of a clinical trial setting, escalating to therapeutic anticoagulation is not supported by strong data and may in fact place patients at unnecessary increased risk of bleeding. However, are there any scenarios where empiric therapeutic anticoagulation might be warranted? One could consider this approach in patients with sudden clinical deterioration with PE, especially when a chest X-ray and markers of inflammation are stable or improving. Or if one has a physical exam finding of thrombosis, such as superficial thrombophlebitis, limb ischemia, thrombosis of dialysis filters or tubing or catheters, or retiform purpura, which are purpuric lesions shown on this slide that histopathologically are characterized by thrombosis in the dermal and subcutaneous vasculature. Microvascular thrombosis may be another scenario where therapeutic anticoagulation could be considered, especially if you're seeing very high D-dimers and fibrinogen levels without any other cause. For those with an absolute indication for therapeutic anticoagulation, such as acute venous thrombosis, atrial fibrillation, a mechanical heart valve, parenteral anticoagulation is recommended until clinical stability is established and the need for procedures is no longer in order. Low molecular weight heparin is preferred over unfractionated heparin given the lower need for exposure and the monitoring that is not as frequent as with unfractionated heparin, and the lower risk for heparin-induced thrombocytopenia. We really need to pay special attention to organ failure that may predispose to bleeding, for example, liver and renal dysfunction. And the benefit of anticoagulation with other anticoagulants, such as the direct oral anticoagulants, must be weighed. The direct oral anticoagulants are obviously convenient, and there's a decreased need for laboratory monitoring, and there's less exposure of the healthcare worker to COVID-positive patients. If unfractionated heparin is utilized for anticoagulation, monitoring with an anti-10A level is preferred over the PTT because, as I showed you before, the PTT can sometimes be abnormal in COVID patients. For acute VTE associated with hospitalization, a standard 3 months of anticoagulation is recommended because these are considered provoked thrombotic events. So are COVID patients post-hospital discharge high enough risk for VTE to warrant extended prophylaxis? Unfortunately, we don't have data in this particular population to guide us on thrombotic or bleeding risk post-discharge. What we do know is that in non-COVID hospitalized medically ill patients, they are at increased risk of VTE up to 90 days after discharge. And they do benefit from extended thromboprophylaxis in certain scenarios. And we do have to consider that there is a slightly increased risk of bleeding with extended prophylaxis. 2 anticoagulants, betrixaban and rivaroxaban, are FDA approved for extended post-hospital discharge prophylaxis in non-COVID patients based on active risk factors for VTE. Enoxaparin also has data in this setting. It's just not FDA approved for this indication. Since most COVID patients remain immobilized for a period of time after hospital discharge, it follows that extended thromboprophylaxis should be considered. In this table, I've summarized currently available recommendations from major specialty organizations for VTE prophylaxis in COVID patients. There's a universal agreement on the need for VTE prophylaxis in all hospitalized COVID patients. Most also prefer low molecular weight heparin, given less frequent injections and the decreased incidence of heparin-induced thrombocytopenia. There's less agreement on the dose of anticoagulant. Extended VTE prophylaxis on discharge is also generally recommended, especially for those with ongoing VTE risk factors like immobility and with a low bleeding risk. Importantly, the feasibility of giving a patient 1 month of an anticoagulant after discharge needs to be weighed in an individual case, taking into consideration the cost of the drug and patient preferences and values. Finally, I want to highlight that all recommendations are mostly based on low quality data in COVID patients or indirect evidence from non-COVID patients, as well as expert opinion. This probably explains to some degree variation in practice. Even less is known about COVID patients with mild disease convalescing at home. Are these patients at increased risk of VTE? One small retrospective study suggested perhaps, given here with the 18% incidence of PE. But as yet, no routine VTE prophylaxis is recommended outside of those patients having significant risk factors for VTE, like immobility, active cancer, or prior history of VTE. Finally, I've compiled a list of major clinical trials that we eagerly await the results of over the next 6 months. These are global, multi-center trials. Most are focused on inpatients, and the last 2 are enrolling outpatients. You see that the inpatient trials are looking at escalating doses of anticoagulation, while the outpatient trials are comparing prophylaxis to no prophylaxis. And I look forward to updating this slide when results are available. So what do we have yet to learn about this disease and thrombosis? Well, there's still a lot of room for knowledge gain here. We need to understand the true incidence of VTE in COVID patients. We need to develop algorithms to identify those susceptible to develop thrombotic complications and severe disease. We need to identify the role of biomarkers and/or scoring systems to stratify patients' risks. We need to design adequate and feasible diagnostic protocols for PE. We need to establish the optimal thromboprophylaxis strategy, and we need to develop uniform diagnostic and reporting criteria. So in conclusion, thromboembolic risk in COVID-19 patients is real, and it's particularly striking in ICU patients. VTE predominance is the common form of thrombosis, but arterial events are also reported. Thrombosis does seem to happen despite standard VTE prophylaxis. Our mechanistic understanding of thrombosis in COVID patients is continuing to evolve, and all hospitalized patients should receive pharmacologic thromboprophylaxis. But optimal inpatient and outpatient anticoagulation prophylaxis is yet to be determined by ongoing clinical trials.